it's time for lunch. You can take your bag and stay here because we have an interesting discussion about the reverse shoulder arthroplasty, mostly technical matters. And we have a discussion with Dr. Antonogiannakis, Dr. Fandridis, Dr. Gervasi, and Dr. Castagna. So please take your seats in the room. Enrico, yes, you too. Καθίστε. Να βάλουμε τα... Μπορούμε να βάλουμε τα μικρόφωνα, παιδιά. So this symposium is sponsored by Osteocell, and I would like to start from Dr. Antonogiannakis. My special stress when I was educated in all orthopedic surgery was not only to implant, but also to reach until implant with the right way the implants. So I want your tips, I want your tricks, I want your advice how we can reach until implant the implants. So how important is the approach for the total shoulder arthroplasty?
So whatever we do, whatever we plan, whatever of thinking of doing, whatever instruments we are going to use, we have to have a clear view, first of all. And surgical approach is maybe the most important, the first thing that we have to learn. All else comes after that. And you can't replace a good approach with any of this instrumentation. Whatever you plan, if you can't see, you can't use. You may have patient-specific instrumentation, you may have any kind of perfect instrumentation. You have to be able to put them into the plane. So, what is, I think, the first thing for any surgeon is to try to have a guided learning on how to get to the to what he wants to do and how to expose it. And this has to do not only with the execution of the operation, but also with the result. We are planning a lot on bones and implants and inclinations and all this. Around them are soft tissues, and we have to take care of those soft tissues, and we have to be able to create an environment for the implant to be able to function.
And okay, we have the right approach, and then we are ready to implant our prosthesis. So, how important is the modularity of the prosthesis? The modularity. How important is?
This is a question for me?
For you.
Okay. It makes everything easier. The idea is to match what we are implanting to the existing anatomy first. Second, the idea is to match what we have, what we are doing to what we plan. Modularity gives us advantage in both of these in both of these things, and also it may allow us to solve problems that we didn't predict it. So variability of the inventory that we have is at least make me feel safe during the operation, feel safer that I am going to reproduce what I planned, or I am going to solve a problem that I could not predict. Anybody else?
I would like to comment something because the title is Mediterranean Way. So I want to say something for my country, Greece. You know, regarding evolution in shoulder arthroplasty, you know, we know that one thing is important. Teaching new things, innovation are coming from the industry. And in my country, we had some problems the last 10 years. One thing is the financial crisis that was European but worldwide. And the other thing that some companies didn't invest in Greece because Greece is a small market. So what is the impact of this? The first thing is on the preoperative planning. We know that systems, you know, very experienced like Blueprint or other systems, they never came to Greece. So my strategy the last years about preoperative planning was always to do CT, 2C, 2CT, and then try multiple planning with 3 CT, and try to use a software that is very cheap and usable by anyone, like Osrix or Radian. And I do in all my cases of arthroplasty a preoperative planning, at least to adjust all the versions, inclinations, humeral, head subluxations. So I used on my mind the preoperative planning, even we didn't have softwares like other countries. So I think this is a message that you can do some preoperative planning using, with no money, systems in the computer like Osrix or Radian. And I would say to young people in my country to use them and try to load the CT, the DCOM images, and play with this, because you have all more information you need. Of course, you don't have the simulation, you don't have the materials, you know, to implant, simulate it, but it's okay. You have a lot information you have before you go to the operating theater.
Yes, I totally agree. I think from this period, the most important message is the preoperative planning. So, Manos, Dr. Fandridis.
Which Manos?
Dr. Fandridis, Dr. Fandridis. We are 3 Manos here, I guess. Give me your tricks and your tips in trauma cases. You are experienced trauma surgeon and trauma shoulder surgeon. So give me your aspect about this.
I think in proximal humeral fractures, I think the last years, maybe the hemiarthroplasty, as we knew 20 years ago or 15 years, declined a lot. Maybe the results are not so good. And I think most of the surgeons, especially the shoulder surgeons, they moved away from the hemiarthroplasty. So I am on the same line. I think hemiarthroplasty, I have some patients, they have great results, but I have many patients with very bad results, and my technique is almost the same. So I think I moved from a hemiarthroplasty, the first case, and now I'm not a nail guy, I'm an ORIF guy. So my case now is almost 100% ORIF or reverse arthroplasty. I like to go for ORIF in young people, and I like to go to elderly people for reverse arthroplasty. Reversing in fractures is not an easy case, I think. If you see the literature, you have more complications than other indications, and you have some advantages like the easier access to the glenoid, because you have the tuberosity, the humeral head away, and you see the glenoid very nice. It's no stiff shoulder. It's not. You try to manage the glenoid, but you have other problems like the height. You have to find the right height of the arthroplasty. You have to resecure and to refix the tuberosity in a different way that you do in ORIF, because we know that reverse arthroplasty created new problems like new impingements. So when you lower the reverse arthroplasty, you have to secure the tuberosity lower, so you have to think of non-impingement with the tuberosities. And the other thing, you have some kind of instability, either intraoperative, and it's nice to have systems that they give you some more stability, like now this system gives the lateralization a little bit. And I think this is very crucial for fracture cases, especially ladies, 70 years old, floppy ladies, you know, that sometimes you feel they're unstable, especially in abduction, 30 degrees and some rotation here. So I think RSA it's a problem. It's not very easy in fracture cases. This system, it's an onlay system, I think it's okay. And the new idea of lateralization, even in fractures, I think gives some solution.
Yeah. So this is, of course, a big topic, the treatment of the fractures. And of course, in generally speaking, I agree with Manos Fandridis. I gave up with arthroplasty because my patient and myself, I was not happy in a big amount of cases. But then we need to classify which fracture we are talking about, number one, and which patient. And we always forget something that is so important. Look at my hands. We are surgeons, we like to operate everyone. Not all the proximal humerus fracture, they need to be treated surgically. And I am treating quite a few of my senior patients with some dislocation of the fracture and so conservatively, and I get similar results to a surgical treatment. So please never forget this about, I don't know if you disagree, you're very welcome to tell me, Alex, you're crazy. I'm not getting offended, but I treat not a few, quite a few fractures of proximal humerus conservatively, number one. Number two, age of the patient is crucial. The pre-op condition is important because this is including an evaluation of the tuberosity, of the cuff, and of the scapula, because a senior one with this kyphotic, it was a great session today, all over. And this should be kept into consideration in indicating surgery and then which surgery. But assuming in an ideal world, I still like plating and ORIF, as you said, Manos, and reverse for the senior, but conservative is also an important option. This is my personal opinion.
Yeah, and aside to this, that we have a conservative treatment, on the other side, we have to train surgeons. The many failures we see are because the fracture is not well reduced. How many times you see X-rays and you see the humeral head flipped in varus, and the articular cartilage of the humeral head is facing the diaphysis. So it will not be possible this could heal. So the reduction, most of the times the failures are for a bad management by the surgeon. And so the first I think I would give as to the youngest surgeons is try to know the anatomy and try to have, in this way, be trained to the anatomy, have a three-dimensional in your brain, three-dimensional view when you just view in a 2D. So you have to know what's back, you have to know how to manage. So how many plates are placed anteriorly with the screws, missing the humeral head or going backward. So these are candidates for failures. How many stems are deep more than they would be, because the surgeon did not check the opposite arm length and did not check how deep the stem should be proud of from the diaphysis. So the tutorial, we do not need now, right now, new instruments, as we need deep knowledge of the anatomy.
Well, since we have a little time, it is important, at least to me, to outline one thing, because you were right. But these are what you are mentioning. They are not shoulder surgeons. They are trauma surgeons. The issue that I have in my country, in my hospital, I'm interacting now very, very nicely with them. But the guys or the girls or the women, they go to see for a fracture the trauma guy. Trauma guys in Europe and in Italy, they are trained by AO. They have a certain approach, A, B, C, and they approach laterally. They do the MIPO, M-I-P-O approach for plating, and they are always happy with the result, because they do proximal humerus, then hip, and then whatever during the day, and their approach is not so much sophisticated as we are about the shoulder. So this is also another issue that we should train not only the shoulder surgeons, because we probably know how to manage things, but the colleagues that are treating fractures, that it is not always us, or at least not me. So this is another problem, that very often I see the patient few months after a plating or whatever that is not doing well because they did such a treatment. But usually this is not done by a shoulder surgeon, but by a trauma surgeon. I don't know if you agree with that, but it is what happens in daily life.
The bad reputation of shoulder surgery in Greece was due to the fact that proximal humeral fractures were treated with hemiarthroplasty from not so experienced surgeons.
So they were doing bad.
Yes, and they are doing very bad, and this was the bad experience that we had in Greece. And there was a conference, and we were discussing it's better not to operate in proximal humeral fractures, not because you have a very good result with conservative treatment, but because either conservatively or surgically you would have the same bad result at the end. And so it's better to avoid an operation. And that's for fracture, but I would like to ask something, to make a comment and ask everybody. Then, I had a period of many years in shoulder surgery and as a shoulder surgeon, and I started doing, it's about shoulder arthroplasty, anatomic and reverse, and about the topic we had early in the morning. So I was operating mainly with hemiarthroplasty or anatomic shoulder arthroplasty. And the results of all this situation were mixed. And then all of a sudden came reverse shoulder arthroplasty. And suddenly the results improved by a high percentage. Slowly, I was turning to reverse shoulder arthroplasty for most of the patients. And going like this, they were coming patients that they had a good result with an anatomic replacement. And I was saying to them, okay, now I'm going to do something different to your other shoulder. I know more now. I was operating them with a reverse shoulder arthroplasty. For the first 3 to 4 months, the patients were amazed with the result. They were rehabilitating quicker, they are better. And they were saying, this type of operation is much, much better than what you did me before. They were patients that they had a very good result with the anatomic. That was why they were coming back to me. So, at 6 months to, after say a year, they were starting complaining. Oh yes, this is so good, but the previous operation is better. It's much better than what you have done to me now. And this was going on like this for 2, 3, 4, 5 years. When I met them, they were saying, both are very good, but the anatomic is better. This side is better. And then, after 6 to 7 years, the things started to change again. They were saying, I think that this shoulder is better than the first one. And they were starting having minor problems, minor complaints, tendonitis, pain, AC joint pain. We have similar problems. And now again, the reverse they were more satisfied with the reverse. So this is a comment, and I want to hear from your experience. The second is that we see slight differences. This is in a successful anatomic replacement, making better. There are some reverse arthroplasties that they are doing perfect. Perfect elevation, perfect external rotation, perfect internal rotation. There are some of them, they are not doing so well, especially in rotations. How we can improve this? This is the question to all. How we can improve this, make a better result in rotation with the reverse shoulder arthroplasty?
In fractures?
In arthritis.
Well, because again, the first comment you did was about fracture, management of fracture.
No.
There is a question from the audience.
Yeah.
Well, I would like to make a comment about what you said, Manos. First of all, I believe...
sorry, I don't know if I made myself clear. What I'm discussing is about arthritis. It's not about fractures. Okay.
Well, I was thinking about fractures. So first of all, I would like to say that you don't do the different operation to the same patient for the same problem. And the second is that there is no doubt that the results of the successful hemiarthroplasty for fracture is much better from the results of a successful reverse arthroplasty for fracture. And this is due to the rotation, the external rotation that the hemiarthroplasty provide, and the problem that the reverse has to the rotation of the shoulder. The great advantage, in my opinion, of the reverse is that you can avoid disaster. And that's the main advantage. Otherwise, if you have a successful hemi, it will be much better than a successful reverse.
Yeah, that goes only also for osteosynthesis.
Osteosynthesis, completely different issue.
Yeah.
For going a little bit further, Enrico, Dr. Gervasi, Offer, you want to...
Just to tell John, I completely disagree with you, and it all depends, again, on a few things, on the soft tissue repair that you do, and sometimes, initially on the design of the prosthesis to avoid the impingement. So you need impingement-free movement below the glenoid in the reverse, and then the soft tissue repair that you're doing. And in my series, and you'll see later in my series, you have excellent rotations in the patients, and I see more predictable results with the reverse than with the hemi. The hemi, you could get good results, but you get horrible results. And with reverse, you get steadily good results and good function. So in my view, there's no point of doing any hemis for fractures anymore. Either you fix them as a young, or you do a reverse for the old ones.
Offer, for anatomic, for arthritis, not for fractures.
Yeah.
How you with a reverse shoulder arthroplasty, we have predictable and very good results. We would like to have excellent results. Sometimes we have, sometimes not, at least in my experience.
Which ones? Anatomic, you mean?
With reverse. With reverse, sometimes we have very good results, sometimes we have excellent results.
Sorry, but we are confusing
Yeah.
a little bit things, too many things
It's
together.
two different, yeah.
Because arthritis, which kind of arthritis,
Yeah.
age of the patient, which kind
So-
of glenoid, because otherwise that's
Yeah,
a mess.
correct.
That's a mess.
No.
If we have eccentric arthritis with good rotator cuff, but also the involvement of the glenoid cartilage with the A something glenoid, anatomic with glenoid. It is very rare to have, in my experience, a perfect glenoid when you have arthritis, unless, we were commenting this before with Philippe, unless you have a perfect indication for the AMI that is atraumatic avascular necrosis.
Yeah.
Period.
Yeah.
This is the best indication with good results. So again, we need to define what we are talking about, because arthritis may lead to this chronic lidl posterior subluxation. We discussed very nicely today.
allow me,
So indication is the first card to play on the table.
I would say something about this anatomic. So I would say that, again, you can get excellent results from anatomic in these cases. However, I will try to avoid as much as I can to put a stem into the shaft. So if you do either a surfacing or do a stemless anatomic, that you can then revise it, because although you want to do anatomic, it's not predictable, and you may have to change. I may say another thing, that in recent years, with excellent results with a reverse, if I have any doubt about either the cuff or the version of the glenoid, all that, I will do a reverse with excellent results.
Allow me.
I would prevent for going straight forward for a reverse, because the patient is 70 years old or so. So the anatomical implants, when the cuff is a healthy condition, and when there's not a huge retroversion, if the surgeon knows how to get the soft tissues under tension, how to repair the sus cape, they go perfectly. And I am concerned about the tendency that is to go straight to the reverse for giving the good anatomical implant.
I would like to ask you about some tips, to give you some tips about the management of bone defects in a reverse.
The bony defect on the reverse, because the reverse is the tool you use when there are bony defects. Mostly you use a reverse, but is a very huge problem. We were talking so few minutes ago about the bony about the trauma cases, and how many trauma cases are managed by the killing the interior proximal humors, both so the head and the tuberosities. So we often, or we many times we have to deal with a bad result, instability or whatever, after a reverse implant, after a trauma. And so this is very difficult. We may have some possibility to manage with a lateralizing implant or with a tuberoplasty made by cement, or we have to go to use a structural allograft, a proximal humeral allograft. So even in this case, we could avoid these disasters that happen when a surgeon is too fast choice to amputate to get the proximal humors to the cut. So I mean that we should give some take-home messages to the other surgeons, because there are surgeons in many hospitals that their choice is the easiest way. So they put a reverse, and they mean that the reverse will give the patient the option of movement and not instability, because he listened that a reverse does not need the cuff, rotator cuff, and tuberosis. This is one of the, as an instance of the problems we can have to manage after first operation. And any other operation can have a low success rate compared to the first one. This about the humeral side. There is a very wide field about the glenoid side. So I am a graft man, but now we have the chance for some augmented implant and so on. But I stay now as a graft man.
Dr. Castagna, you mentioned the importance of knowing the history, and you know very well the history of all the evolution.
Yeah, because I'm an old man.
No, because sometimes you have created also. So I want to ask you about the future. What do you believe is the evolution of all, for the reverse, what will be the future of our approach and the procedure?
And after you.
Well, the evolution is already on the way, because we started with this medialization of the center of rotation and lengthening of the lever arm of the deltoid, and it was a great idea from Paul Gramont. And then we understood that the wrapping of the deltoid should be improved, so we started what we call lateralizing. That to me is just restoring the proper joint line and keeping the center of rotation somewhere more close to what is needed for the deltoid. So something in the understanding is already on the way. But then the shape of the glenoid is important. But I think that having some imagination and following what JP said today, and also listening to the previous speaker in the morning with this pre-op planning, we are starting there a long itinerary. We started with the PSI that is helping us so much to improve, but also to understand our mistakes. And we still don't know exactly how to teach our machine, how to develop the perfect system, but it is again a progression. And imagine that when we are there, again, the cartilage or not the cartilage, the retroversion, how much we can accept, and all this stuff. So the idea for the future is that we are able to reconstruct something that is keeping into consideration the soft tissues that we are not considering now in the pre-op planning. And I enjoyed the presentation that was done this morning. So this is the future: soft tissue evaluation and the scapula position on the chest, because this is so much influencing the shoulder in generally speaking, but also the reverse prosthesis. So analyzing soft tissue and scapula position is probably something that is crucial to make a significant step forward in our implants. But of course, imagination that needs to become a reality. So far, it is still a little virtual.
Yes, Dr. Gervasi.
I mean that in the future, probably not so far, the problem that we have going to have to distalize the base plate could lead the manufacturer to have the glenoid fixed in the center of the glenoid, where there's a bony purchase with no reaming of the distal part, and probably an eccentric glenosphere that goes distally. Otherwise, we have to ream the distal part, and we can have a bony deficiency at the first implant, and probably this would be better because if we implant a metal back base plate, we put it centered, and when we have to go to a revision because you now have a rotator cuff tear, and so you have to manage for a revision to a reverse, we have the base plate not in the optimal position. You should use eccentric glenospheres, but I mean in the future probably we will have the same center of the base plate, both for the same center of glenoid position, both for the anatomical and for the reverse.
Okay. Yes, Manos.
So, Manos, going back to present, I want to say that for us in our country, one message is that we have to move from the long stems now to the short stems or stemless. We have to do it here in Greece more and more. This is a Mediterranean, I think, so we have to stress on that. We have to move from the long stems to the short stems and the stemless. So for the Greek colleagues, they should ask from the industry to go to this. And the other thing, I know John, he's doing reverse so many years. He always believed in grafts. He do it with different ways. But now the second message is that we need sophisticated instruments for grafts. I think so. We should ask from the companies and industries also to have some help, assistance, instrumental, I think, for the grafts, because I think we need grafts.
Yeah.
This is my opinion. And my third approach is that we have to know well the systems. The systems are different, so we have to know a little bit more sophisticated systems. There are the inlay systems. There are systems that do more lateralization from the glenoid, some others from the humerus, some others both. So I think when you use a system, you have to know how much medialize or lateralize the center of glenoid, because it gives you a better perspective with your patients. And the question of Antonogiannakis maybe was about the rotation in reverse arthroplasty in some indications. And there's no answer, maybe. We know the papers about more destabilization, more tilt, but I think there is no clear answer about internal or external rotation about these systems.
I think now it's the time for you to have the lunch. So this was the end of the symposium. We tried to highlight the Mediterranean approach, and I will thank the speakers for the participation.
There is a question. Offer.
I want to congratulate.
You like to invade in the Mediterranean.
Yeah, I'm Mediterranean as well. Eh?
Yeah, he is Mediterranean. More than us, almost.
Okay.
Yeah. So I want to congratulate Manus Fandridis for finally, after almost 20 years that I'm preaching about the stemless reverse shoulder, he thinks that this is the future. So hopefully we are starting to win.
Yeah.
Okay. Thank you very much. And thank you, Osteocel and Lima, for this symposium.